Hello everyone, I'm really happy to be here today and be able to talk about quality of life in patients with lipedema and Dercum's disease. I am PhD candidate at the University of Social Sciences and Humanities, and I've submitted my dissertation a few days ago, so I will present results of my dissertation. I did my dissertation on quality of life in women with lipedema, so I will present that, and I will also relate certain aspects of my presentation to quality of life in people with Dercum's disease. I have nothing to disclose. And here's the model that we use to conceptualize certain patient outcomes that we can measure when we talk about quality of life. In patients with lipedema, I think that this model might also be helpful to people with Dercum's disease with some minor changes. As you can see here, it's not about only biological functioning, but also how this biological functioning or biological impairments affect symptoms that we experience and how those symptoms affect the way we function. And we think here about physical functioning, for example, mobility, and also psychological functioning. As a psychologist, I decided to focus more on this psychological part of the disease. So you will see results of a questionnaire asking about appearance-related distress and also measurements related to depression, anxiety, and eating disorders. We also have characteristics of individual, and because I'm behaviorist, we focus on those characteristics that we can change through interventions and improve in order to improve quality of life. As you may see here, this model also shows characteristics of environment because the disease, lipedema or Dercum's, happen in certain environment. And as you all experience that, the environment is that there is lack of knowledge about the disease, lack of knowledge about treatment, that many people experience reactions from society or from peers, from friends. What is this? I've never heard about it. And it's closely related with weight stigmatization that is very, very often in many settings, in educational settings, in healthcare settings, in media. So therefore, it makes it even harder for people who suffer with lipedema or Dercum's disease to cope with the disease because of this lack of knowledge. So I just wanted to acknowledge the difficulties that are in the environment. We did two studies on quality of life in women with lipedema. One consisted of 120 participants and the other on 328 participants from all over the world, mostly from United States, but also from other countries in the world. Mostly middle age, with BMI between 20 and 40. As you might assume, satisfaction with life was low. Here you have a chart which shows that almost more than 50% of surveyed women reported that they are dissatisfied or extremely dissatisfied. When we look at quality of life, it's also low. You can see it in green columns. Here in gray ones, you can see a norm for general population. Of course, we cannot compare them statistically. However, we can see that we can assume that the quality of life in women with lipedema is low. What about Dercum's? So there is one research by Hanson and colleagues that shows that the quality of life in people with Dercum disease was lower than in a control group of people with obesity without pain, without any associated conditions. And it has grown after liposuction, but it didn't reach the level of the quality of life in the group, in control group. So we might also assume that quality of life in people with Dercum's is also low. And why is that so? So first of all, because of the symptoms. And in our research, we showed that the symptoms predict quality of life. Here I want to focus on particularly on those symptoms that are most severe and they might be most important for quality of life, which is pain and fatigue. And I will also mention associated medical conditions. So in our first study, more than 40% of participants reported severe or extremely severe pain. And results were similar in our second study. Moreover, many women reported severe or extremely severe fatigue. Pain and fatigue is common for lipedema and Dercum's. However, in Dercum's, the level of pain is higher than in lipedema. And there are some other associated, some other symptoms that might impact quality of life. When it comes to associated medical conditions, the more associated medical conditions, the worse quality of life. And here there are some from our research in women with lipedema, for example, arthritis or venous insufficiency, also hypermobility. And here these are from article on Dercum's disease, fibromyalgia, and as we heard yesterday, diabetes. Symptoms impact how we function with the illness. And in our research, we focused on two aspects of this functioning. One is mobility, and the other is appearance-related distress. We measured mobility with lower extremity functional scale, and this scale measures ability to perform daily activities such as standing for 1 hour, getting into or out of the bath, or walking between rooms. And this scale allows us to count something that we call maximal function. Maximal function is like if we have 100%, it means that we are completely mobile, we can do everything. And in our research, after we counted this maximal function, we noticed that more than 50% of participants, almost 60, had just half of maximal function. So they couldn't do half of the things that people who are completely mobile can do. And this mobility was also related to lower quality of life. So the lower mobility, the lower quality of life. We also looked at the appearance-related distress, as we've noticed that lipedema is a visible we can call it a visible difference in appearance because this is a disease that is visible, that can get stigmatized. And here you can see results of the Riford appearance scale. This is a scale to report distress and avoidance related to visible difference in appearance. And in orange columns, you have results for each age group for women with lipedema. In gray one, this is norm for general population. And in blue one, it is a norm for clinical population of women. So women who have some visible differences in appearance, not necessarily lipedema, but more like facial differences in appearance and other ones. So you may see that this appearance-related distress was quite high. And here are some example questions to show you that this appearance-related distress affects many different areas of life. As you might see here, many women were distressed with going out, social meetings, going to the supermarket, going to the beach, which is something that is close to going out to a swimming pool, and we know that swimming, for example, is very healthy or helpful in managing the condition. I haven't found anything that I could compare in Dercum's disease, but I guess mobility might be also an issue there, maybe some other issues. And now I will move on to psychological functioning. So we focused on depression, anxiety, and eating disorders. And we used questionnaires that are used in clinical practice to assess the severity of those disorders. And according to our results, more than 36% had moderate to severe anxiety, and more than 50%, almost 60%, had moderate to severe depression. And that is a really high rate. It is sort of similar to what we noticed in Dercum's disease. As you heard yesterday, depression was no different between people with lipedema and Dercum's. So here, this is a study that shows that in people with Dercum, it was 66%. And here, anxiety was much higher, 85%. The other study shows that compares people with Dercum disease with a control group of people with obesity but without pain, shows that depression was higher in people with Dercum disease. And those symptoms of depression, like feeling of helplessness or self-loathing or loss of interest in daily activities, or even suicidal thoughts, sometimes it's anger or irritability. All of those symptoms, they are related to lower quality of life. In our research, we showed that the higher the severity of depression, the lower the quality of life. And moreover, it might impact the progression of the illness, because if we lose interest in daily activities, we have difficulties in self-management, we might have difficulties in eating properly. So depression seems to be very important in managing the illness. And women with lipedema are, and also I think people with Dercum disease are at risk of depression because of certain factors of the disease itself. For example, lack of control over disease. That is something that, for example, a person is trying to take care of themselves, eating healthy, exercising properly, going to a doctor, but there is no change, or the illness is progressing, or they are trying different drugs but nothing helps. So that might lead to learned helplessness, which might be a mechanism underlying depression. The other risk factor is restrictive dieting. If, as you heard before, food is very important, nutrition is very important. If someone is on a restrictive diet for a long time, they might have some malnutrition that might lead to depression. Also pain. Pain itself is closely related with depressive symptoms, and there are some theories that say that maybe underlying mechanism is actually neuroinflammation or some other mechanisms that are responsible for co-occurring pain and depression. Lipedema leads to impaired mobility, so that is related to lower physical activity, or might be related to lower physical activity, which itself might also be a risk factor for depression, as well as loneliness. Loneliness that might be a result of experiencing weight stigmatization or fat shaming. Research showed that people who experience weight stigmatization or fat shaming are at higher risk of depression and other mental health problems. Therefore, I wanted to say that focusing on depression, monitoring for depression, and treatment of depression is important. And it is important because of some vicious circles also, because people who are depressed, they experience more pain, and the more pain they're experiencing, the depression is getting more severe, or might be getting more severe. People who experience depression might have difficulties in engaging in new activities, in maintaining physical activities, might have difficulties in keeping healthy eating patterns, or in having some social interactions. And I will show you later how important is social connection for our health, mental and physical health. So therefore, depression should be treated. And I wanted also to talk a little bit more about eating disorders. So here are results of our first study. And in orange columns, you can see mean scores for women with lipedema. And in gray columns, you can see norms for general population. In second study, we had so many questionnaires that we couldn't ask about eating disorders, so we just asked in self-report, and in self-report it was 31%, and I think we need more studies on that, like to see how often eating disorders happen. And here are some symptoms of eating disorders, like overly restrictive dieting, excessive focus on appearance, food and weight, binge eating episodes, purging after meals, self-esteem depending on body weight or shape, shame related to eating. And the problem with lipedema and eating disorders is that many women are given advice to go on a diet, and diet is not working, and there is a kind of vicious circle between strict dieting and binge eating, or over evaluation of shape, weight, or control over eating. And therefore many women, when they are not able to keep up with the diet, for example, or they don't get results, they start blaming themselves, and that might keep them in the loop and lead to developing an eating disorder. Therefore, we need to also be careful how we give advice on eating, and also to monitor for eating disorders and to treat them if they happen. Also because eating disorder themselves might aggravate symptoms through lowering the metabolism and also binge eating episodes. And now I wanted to move on to characteristics of individual. As a psychotherapist, I'm always interested in what we can do as psychologists, as psychotherapists, in order to help. And we focused on two factors. One is psychological flexibility. It is an ability to accept what you cannot change and focus on what you can change. So no matter what life gives you, you can always do something with it. I mean, you can accept what you cannot change, and fighting with it is not helpful, and focus all your energy on what is in your control. And psychological flexibility is a concept that is related with better mental and physical health. It is used in areas of chronic pain, with fibromyalgia, with stigmatization, with depression. There are some research that show that, for example, increasing psychological flexibility in people with chronic pain, even if the level of pain is not changing, they might have better quality of life. This is an ability that can be learned, that can be practiced, and that increasing it might lead to a better quality of life. And in our research, we found out that psychological flexibility was related with better mental health, a lower severity of depression, anxiety, and eating disorders, as well as lowered appearance-related distress, higher mobility, lower symptom severity, and higher quality of life. The other very important factor is social connection, and we all know that social connection is important. It's important to our mental and physical health. My favorite research that shows how important and how powerful is social connection is research with wounds and wound healing. It was research in which couples were invited to a lab, and they were supposed to talk about a topic that is related to a conflict. And they measured how much hostility is between two people in the couple. And then they were made suction blisters wounds, like wounds with suction blisters, and they measured how fast wounds were healing. And it appeared that wounds were healing much faster in those couples where level of hostility was lower. So this is really nice research that shows that social connection and having close, warm, loving relationships might actually impact us on a very physical level, even like wound healing. Therefore, it's very powerful, and it can also be learned and practiced. Actually, we are practicing and learning that at this conference. This conference is such a wonderful opportunity to practice and increase our social connection. And in our research, it was related with higher quality of life, higher satisfaction with life, lower severity of depression, and lower appearance-related distress. So, to sum up what I was talking about, not only symptoms, but also functional status, so for example, mobility and appearance-related distress in case of lipedema, and psychological functioning, for example, depressive symptoms, might be important factors that predict quality of life in women with lipedema, and we might assume that some of, especially symptoms, mobility, and depression or anxiety might be also related to quality of life in Dercum disease. However, it needs further research. Symptoms might have impact on our functioning, and our functioning, everyday functioning, might also affect symptoms. So if our level of mobility is lower, or if we have associated depression, then we might cope with symptoms worse. Therefore, it's very important to look at the management of the illness broadly, not only on physical side, but also on psychological side. And one of the conclusions is that psychological flexibility and social connection might be important in improving quality of life with lipedema and maybe in Dercum's disease. And what are the implications for treatment? So according to our results, symptom severity, mobility, appearance-related distress, and depression are important factors that should be treated or prevented. Like we should prevent immobility, we should prevent depression, or if it happens, we should treat it. And we can do it by social support, by building social support networks, by treatment, group or individual. And when it comes to appearance-related distress, what we can do, these are some interventions that are related with increasing acceptance of one's body on one side. And on the other side, these are all those interventions that we do to decrease the level of weight stigmatization, so to share the knowledge of lipedema, Dercum's disease with people around the world, that they can understand what kind of illness it is and give us the support that we need. And I think that this conference is also doing great job, and FDRS is doing a great job to do that, to increase the level of knowledge. And another thing that is important, that mental health obviously should be assessed, and patients at risk should get some treatment. And patients might benefit from support groups, sharing their experiences with others, getting support, as well as increasing psychological flexibility. In the end, I wanted to thank Tilly Smith for helping me with the second survey, and my colleagues from University of Social Sciences and Humanities in Warsaw, Professor Ostaszewski and Białaszek. And also to Jonathan Cantor from University of Washington in Seattle, and David Gelenders, who also helped me with the study, and to all participants, and to all of you for listening to me. Thank you.